Good morning and welcome to Health Talk here. There we go. We got to stop that. Good morning and welcome to Health Talk here on AM 1270 and 96.5 FM KXVX. My name is Paul Thomas. In the studio today with Bill Kearney of Northlake Medical Pharmacies. Welcome, Bill. And beautiful day after some nice rain over the weekend.
Yeah, gorgeous out there. I just got back from New Orleans last night about 6 o'clock, and we had some beautiful weather there. It was the mid-80s in the daytime and the mid-70s at night. And heard about the rain here, and my wife was here, and I think we got over 2 inches of rain.
It was a really good storm. It was decent.
I noticed when I got back all of our flowers that I thought were dead for the summer had all rejuvenated. I guess I hadn't been watering them quite enough.
Well, and it's like our lawn. We've got grass sprouting now.
Yeah,
where it was just dead from the summertime.
Well, it's good to be back, and I think everybody that I was on the plane with had some sort of cough or cold or a sneeze, and the whole time I was in New Orleans, it seemed like everybody had some sort of congestion that of course I picked it up too. So, but we're getting into the winter season now, and flu shots were giving like crazy. I guess I wasn't here Monday. I guess it was just crazy on Monday giving flu shots. So. Don't hesitate to get your flu shots. There was an article, I can't remember if it was in the New Orleans paper or if it was in the Press Democrat yesterday, about the H3 part of the trivalent vaccine, and they feel like the H3 is the most severe strain of flu that's going to be here this year in our area, and it's very imperative because it's one of the toughest flus to treat. So. Remember, most of these flus are viral, and we have to be immunized ahead of time. So, and it takes about 2 weeks to build up an immunity. So, if you haven't got your flu shot, walk into our pharmacies and get immunized as soon as you can. And if you're over 60 or 65 and haven't had your second pneumonia shot in your lifetime, then get a Prevnar 13 or a Pneumovax 23. At the same time. One's a live vaccine, and the other's an inactivated vaccine, the flu vaccine. So you can get one in each arm. And I know people aren't crazy about needles, but if you're in that age group that's susceptible to pneumonia, over the age of 60, and also in the more prevalent people that get the flu, it's a healthy decision to make, and Medicare pays for both of those drugs for you, as well as worrying about Zostavax, although Medicare does not pay for Zostavax for shingles. A lot of the Medicare D plans do. So when I was in New Orleans, we were talking about health coverage and how things are going to change after the election, no matter who gets elected, and we've talked about that before. There will be some severe changes, as there is going to be this year on Medicare D. If you'll notice, your premiums are going up, your copays are going up, and the formulas of the drugs that they cover is going down. So any way you look at it, it's a bad thing for healthcare. So our healthcare system is broken. We need to fix it, and we need to key on one of the as many things as we can do to get the healthcare system changed. So one party wants to completely throw out Obamacare. We had pharmacists from all over the country that were store owners, and they seemed almost equal in their feelings about getting rid of it or altering it. So we save the good parts of it and get rid of the bad parts. And some people want to get rid of the whole thing because they think it's bad. The difficulty is knowing what's in the health care plan. As we've talked about before, you were asked, our congressmen and senators were asked to just sign it, read it later, It's over 2,000 pages, and of course we aren't getting to page 1,999 yet. There's as the years accumulate, more and more of those things go into the healthcare plan that really had nothing to do with healthcare. So we're struggling to try to keep up with the costs. Our big focus in New Orleans was how much longer can pharmacy survive the reimbursements that were being cut. Right now, Medi-Cal is taking 5% off of every check that we get, and we have fees called VIR fees that aren't prevalent. We don't know what they are when we fill your prescription, so we could be losing money as we fill the prescriptions and not even be aware of it. So in Congress, we're trying to change those things so at least we have the option. And many times, some of you will come in and we will say, I'm sorry, we can't fill the prescription. You will call your insurance company and they said, we do cover that drug, but many times they don't cover the cost of the drug. They expect us to fill it at a loss. Unfortunately, we can't afford to do that. Our average net profit in pharmacy worldwide or nationwide is 2.3% of our gross. Not very much when you're small independent pharmacies. Big box chains that have a huge front end that can make the money off the front end are able to survive even a lower net profit than that. And I'll guarantee you most of the time the pharmacists fill the prescriptions. They have no idea whether they're winning or losing on those specific medications. So today we're going to be talking about a lot about diabetes and some about cancer. And one thing that plagues most of us today is why you're so tired all the time. And as you go through the aging process, it seems no matter how much sleep you get, you're still exhausted. And what's that all about? What's going on? And as we dig into that a little bit further, we realize people go to the doctor with a whole list of syndromes that you found on WebMD that might be to blame, considering addressing the single most probable cause of fatigue is good old-fashioned sleep deprivation. And Paul, you know what that's like, and you know what the difference is. And
that's huge. Yeah.
We often shortchange ourselves on sleep and try to fit more stuff into our lives. And I think that's one of the problems, either for work or exercise or as much needed time alone. And seldom do we get that anymore. Paul, you're living in a family that's got, small kids, and a lot of family members come and go, and that's the way it is for a lot of people who are raising kids that, and I'm not referring to you, but a lot of grandparents are raising their kids as their grandkids now because there's either been a relationship strain or they're not able to afford to reason. So there's other causes for fatigue, of course, besides not getting enough sleep. So when patients come in complaining of exhaustion, the doctor's going to ask you about clinical things like shortness of breath, or maybe there's an underlying hypothyroid, meaning you're not getting enough thyroid that's causing the fatigue. If you're going through menstruation, as a woman, you're losing blood clots every month, which have oxygen in it. So that's or a restrictive diet. So they ask about things that might be accompanying a true loss of sleep that has to do with something other than not getting enough sleep. So when your lab work comes back clean and the doctor finds out that you don't have a thyroid problem, and then they start looking for something like chronic fatigue syndrome or fibromyalgia or any of those other drugs, and they're still underlying diseases that could cause those kind of things, and people have to start looking at that. That's an expensive process because we don't know, like fibromyalgia, at least 3% of the population in our country, in the United States, is affected, and it's primarily women. But we know how those people's brain processes work in pain and stress, and in fact, sleep disturbances and muscle tension and pain are a trigger that has gone haywire, and in short, you're exhausted all the time. So the primary thing is to prioritize when you're going to be getting the sleep. And one thing we don't think about is the fact that there's a lot more causes to not being able to sleep. And one of those causes is the fact that your mind affects sleep, even with insomnia. If you're depressed or you have a lot of anxiety, our beliefs and behaviors towards sleep influence our sleep quality, regardless of whether we're living with a primary insomnia, which is caused by just a lack of sleep, or whether it's something that your brain is causing you to have that problem. So there's a difference between primary insomnia, being able not to sleep, and secondary. So primary insomnia is thought to arise primarily from negative and incorrect thoughts towards sleep and physiological factors such as too much anxiety. To be diagnosed, an individual needs to be experiencing symptoms that are not attributable to mental or medical or environmental cause. Secondary insomnia is far more common, accounting for nearly 85 to 90%. It's also a result of another condition, such as chronic pain, medical disorders, psychiatric disorders, or things such as sleep apnea and restless leg syndrome. I have a person in my family that has RLS, restless leg syndrome, and doesn't sleep much because of that. And at least 67 to 84% of the people living with depression also suffer with sleep disturbances, and 2 out of 3 individuals with generalized anxiety disorder report at least one type of sleep disorder. So they did a study, and I'm great on studies. This wasn't a huge study, but all insomnia groups reported living with sleep disorder for over 6 years. There were no significant difference when it came to the severity between the different groups. There were good sleepers. There were people living with primary sleep deprivation. 17 were living with insomnia and anxiety. 39 living with insomnia and depression, and 66 were living with insomnia, anxiety, and depression. And they went through all kinds of tests on sleep hygiene, the severity of the lack of sleep. The study found that those insomnia with depression and insomnia with anxiety and depression had significantly higher, more difficult problems. So most importantly, those scores and attitudes about the sleep scale were significantly higher than the scores of good sleepers. So the conclusion was that they may have similar negative thoughts and anxieties, and that has a lot more to do with your inability to sleep than anything else. And then when you consider the medical disorders that go along with it, and depression and anxiety, this alone can't explain the difference in scores. But if you start adding the RLS and side effects of medication that can cause sleep anxiety, and the other factors that chronic pain, there's a major reason that as you age, that becomes more difficult to control. And as we get older, we get up in the morning and we don't feel rested. We don't feel like we got good sleep, and you could have gotten 7 or 8 or 9 hours, but the amount of that time that was good REM sleep was probably very short. Paul, I never dream, or if I dream, I don't remember it.
Ever? Or just recently?
Well, no, just most of the time I don't remember dreams. Like some people wake up, and so this was really unusual. I didn't take any medication for my blood pressure and my anti-inflammatory that I don't take otherwise. But when I was in New Orleans, I had dreams all the time. I don't know if it was the
voodoo that was on
the voodoo or what it was. But I didn't sleep, and I was going to meetings from 7 in the morning until 8 or 9 at night for 3 of the 4 days I was there, and I was really exhausted when I got there. And then my time clock was off, of course, because New Orleans is on Central Time. So I was 2 hours later than I was here, but I couldn't get to sleep as fatigued as I was. And then the short period of time that I was asleep, I had dreams. They weren't bad dreams, but I just never could remember dreams before. Now, I can't tell you exactly the part of those dreams that was rememberable, but I just remember I had dreams, and I would get up and get a glass of water or something, go right back into the dream. And I had that every night I was there. Last night I was home and fatigued, and I was on, I usually go to bed at about 10 o'clock, and last night it was 11:30, and I still couldn't sleep. And but I did get to sleep, and of course I got up at 5 like I usually do, and didn't remember dreaming about anything. I guess psychologically, I guess you do dream all the time, and it's just a matter of remembering. Do you remember your dreams?
Not really, just kind of vaguely. But I used to never dream because I would never be asleep. Before I got on this CPAP machine, and now I do dream.
Yeah.
And I couldn't tell you right now what it was, but it's interesting because my wife will wake up and she'll be like, "Oh, I was having the best dream," or she remembers her dreams like really, really well. But I've never really, paid attention to them or tried to consciously remember them. I guess maybe if I tried to, I could, right when you wake up. But
well, if I won the lottery, I think in my dream I would have remembered that, and I would have gone to the casino or something. In fact, I went to the casino once, Harrah's, which is right across the street from where we were having the meeting, and I played a little poker machine. And I'd put, I don't know, 20 or 30 bucks in there, and I lost it all. I got down to $5, and I was just tired. I left we had a cocktail reception at the Pharmacy Museum in New Orleans. And I was walking back, and I walked in there, and I was down to $5, and I just wanted to get out of there and go home. And I got down to 50 cents because it was a quarter machine. And I had $210 on a Royal Flush.
No way.
And if you play a poker machine, you don't, it's not like sitting up at the table and playing it. And I thought, I just want to get out of here and go home. And I had a quarter left, and I guess 50 cents left because it was a 50-cent machine. And it was $210 for a Royal Flush. I picked up the money. They don't even have cashiers there. You have to go to an automated machine
and put
your ticket in, and I had to figure out how to use that because I've never won anything. These two ladies were standing there and says, "How do you do this?" And I said, "Gosh, I'm not sure." I followed the directions. It's like when you go to the airport now, you have to fill out your own name tag. And anyway, I would have remembered that dream if it had been bigger.
That's awesome.
But that was
that's a great.
And I had discipline. I got out of there. So now we're getting into the fall weather, and you're going to realize how the weather. We talked a little bit last week about how you're more apt to get a disease and things from being inside more. But you might think a little bit about how the change of season can affect your skin. And you don't think that it does, but it does. And making small changes in your skincare can help protect your skin during the colder months. Wind, which we don't necessarily have a limit on how much wind we get here, or even in the summertime, but fall in much of the northern part of the United States is extremely windy. Blustery days and then when the wind goes by your face, of course, you get a lot of windburn and dries out. You look sunburned, and you get this dryness of redness and peeling. You need to keep your skin protected by wearing a high collar and maybe a scarf. Not so much in our part of the country, although we get to those parts where it does happen. And use hats to help protect the upper part of your face, and I don't wear hats, and kind of minimize your face before going outdoors, before you come indoors, use a sunscreen outside, which can help protect you from the sun and limit how many activities you experience in windy days. We don't really have that option here, but we do have some bad weather that comes by, and we need to protect ourselves. The sun, a lot of people pack away their sunscreen when summer comes, but fall and winter can be just as damaging to your skin. The sun rays pass through the glass and bounce off surfaces such as water, snow, and ice. If you're a skier at all, and it was interesting, when I came through Denver yesterday, there were people with skis already going up in the mountains and skiing. But that's an extremely susceptible place to get a sunburn because you're at a higher altitude and there's nothing that's diffusing those sun rays. So even when your skin doesn't feel warm, it can damage your skin, causing skin cancer. So sun protection in the colder months and the same as sun protection in the warmer months. Remember that that also can occur on cloudy days. I don't know how many times we've gone to the coast here, and you too, Paul, go in and it's a cloudy day and you don't think that you're getting burned, and you're getting you're getting burned, and sometimes really severe. So look at your sunscreen, check the expiration date on it. Even if it doesn't have an expiration date, look at the consistency of it, because it becomes rather fluid, liquid, and when it becomes more of a lotion than a cream, even though it's supposed to be a lotion, it will become really milky. It's not protecting your skin. One of the things that we forget on sunscreens, especially in the winter, is putting it on 30 minutes before you go out. It's a chemical reaction that takes place, and you need to make sure that sunscreen is on you before you go outside. The outer layer of your skin, which is made up of fats, and some of us more than others, you need to help your skin moisturize. Those fats break down. They call them lipids, but in cold weather, causing your skin to dry. So a lot of people, if they have a fireplace or a wood stove, they either have a humidifier in their house or they put a tea kettle or something on their stove. Use a moisturizer and a summer moisturizer for an oil-based one. Apply it at least twice a day. Protect your lips. We were giving out sunscreens through the co-op, lip balms, and they were going like crazy because a lot of the people from the East Coast and a lot of skiers. So just remember that psoriasis and those kind of skin conditions get a lot worse in the wintertime. I came back from New Orleans and I was sitting on the airplane and I was just scratching all over because I have dry skin. I usually swim every night, and I wasn't swimming there, but my skin dried out considerably. And there didn't appear to be the humidity that normally exists in New Orleans, and so it was relatively dry as far as the humidity goes. And if you were out in the sun very much, which I really wasn't, you would have more of a chance for something to affect your skin because of the time of year it is. We're going to take a break, and when we come back, we're going to talk a little bit about cancer just doesn't boil down to bad luck, and then a few things on diabetes. Have you recently been discharged from the hospital or special care facility, and you need help in getting around your house? Hi, my name is Bill Kearney, owner of Northlake Medical Pharmacies in Lakeport. My wife, Dana, and I own Northlake Medical Pharmacies in Lakeport. And for the last 6 years, we've been offering a new service in Lake County. Both our pharmacies now sell and rent hospital and medical supplies. So if you need a walker, a rollator, a wheelchair, or a transport chair, we'll rent them to you or sell them to you if you prefer. We also have lift chairs and hand, wrist, knee, leg, and back braces for your comfort if you need them. If you're looking for a pharmacy that has great service, a $4.99 month generic prescription plan, free delivery service to Lakeport, Upper Lake, Nice, Lucerne, and now Kelseyville, as well as rental sales of medical supplies, then you need to come to Northlake Medical Pharmacy on Hill Road across from Sutter Lakeside Hospital and in front of the Reynolds Shop Smart on Lakeport Boulevard.
A single ember from a wildfire can travel over a mile. It can ignite and destroy your home and even your community. To that ember, all those branches hanging over your roof might as well be giant matchsticks ready to spark. The pile of dry leaves and twigs clogging your gutters are the perfect kindling to start a fire. And all those debris piles and brush around your yard which you haven't taken care of yet are pure lighter fluid, ready to ignite. There are some fire hazards that aren't clearly marked, and they can impact you and your neighbors. Learn to spot them, because your home is better protected from wildfire damage when your whole community is prepared. Visit fireadapted.org for more tips on how to get started adapting your home and community to wildfires. A public service message brought to you by the U.S. Forest Service and the Ad Council.
Sergeant Jason Nielsen served his country as an MP in Iraq.
I was in Iraq for 10 months before I was hit by a sniper.
He suffered a paralyzing injury, ending his military service. Paralyzed veterans of America's national service officers, such as Sharita Latham, are trained to help injured veterans get all the benefits they've earned.
She worked with my wife, took care of everything for me just so I could focus on just recovery and trying to get on with life.
To learn more, visit tva.org.
It may not require a textbook, but it's filled with valuable lessons. It may not take place in a classroom, but it's an ideal environment for learning. It may not involve a diploma, but it can help prepare California's young people for life. High school sports. High school sports can play a critical role in a student's overall education. In fact, studies show that students that participate in high school sports are more likely to enjoy greater levels of achievement in their academic lives. If you think high school sports are only about competition, think again. Better yet, think about attending a high school sporting event in your community. You'll be amazed by what you see. High school sports, a winning part of a complete education. This message presented by the California Interscholastic Federation and the California State Athletic Directors Association.
All right, we're back.
Well, I saw an article today about cancer when I was on the Medical Daily Journal, and it says cancer doesn't boil down to just bad luck. So these was studied by researchers to directly measure DNA errors in human stem cells from different organs, and they're talking about cells that are constantly bombarded by external forces that damage the DNA, whether it's cigarette smoke or sun, and as that accumulates over time, it can lead to cancer. So we can minimize our exposure to external forces. Sometimes our own cells work against our body, but errors in cell division and other processes can result in random mutations or bad luck. But I seem to be pretty prevalent on the bad luck part. But previous research has suggested that these bad luck DNA errors accumulate over time and increase the risk of most cancers. But researchers, and this was in the Netherlands, analyzed stem cells left over from tissue samples. Those cells were gathered from the colon, liver, and small intestine, which have starkly different rates of cancer incidence. The cells belong to patients from a varied group from 3 to 87 years old. This was published Monday to directly measure the DNA errors, and we were surprised to find roughly the same mutation rate in cells from organs with different cancers in incidence. And it suggests that simply the gradual accumulation of more and more bad DNA errors over time cannot explain the difference we see in the incidence of cancer. So it seems that bad luck has something to do with it, because there was an accumulation in different organs, but it didn't vary that much. And we need a lot more evidence to find out if that's true, but lifestyle factors, which we've always held up as being a factor, as smoking and diet, can account for part of the difference in the incidence of cancer. The new research says this DNA error accumulation is important for the first time, and pretty much the cancer risk is down. with a lot of these errors taking place, but essentially they haven't ruled out the accumulation of DNA in this process because they thought maybe that was a major source of the reason of the incidence of cancer, and it doesn't appear that at this point anyway, with the studies done, and I don't know how many people were involved in the studies, that the lifestyle risk that we take is over and above that part of the DNA errors, and it's caused by the different things that we have thought in the past, cigarette smoking, lifestyle changes, alcohol, lots of different factors that aren't new factors. We still hear this thing about radiation and living under electrical towers and cell phones and those kind of things, and we haven't put all those things into the margin that really will give us a definite answer on whether or not these risk factors are high enough to do something about it. So diabetes is a huge issue in our country, and people need to know what we've talked about several times: diet and exercise, diet and exercise, diet and exercise. And one of the things that we don't talk about much is what kind of exercise. And there was a study done about if you have type 2 diabetes, which is the one where your pancreas makes insulin. It just doesn't make enough insulin. And you don't normally have to take insulin therapy. You take medications that work differently. And what they found out was if you have type 2 diabetes, the best time for you to get physical activity is after you finish your meals. But the current guidelines don't suggest this because this is just new information. But when you have type 2 diabetes and you walk after eating, the blood glucose levels average a drop of 12% more than at any other time during the day. And this is the walk that you take after eating. And this is a conclusion of a randomized study that the Journal of Diabetes first published on October of 2016. They found people walking, they researched people walking to 41 people with type 2 diabetes and 2-week blocks separated by a month. The people in the study were instructed to walk either 30 minutes a day or to walk for 10 minutes. And you'd be interested in this. After each main meal, starting in 5 minutes after they finished eating, when they took their 10-minute walks, their post-meal or their after-meal blood glucose levels averaged 12% lower than when they took a 30-minute walk at the same time during the day. Most of this effect came from 22% reduction in blood sugar when walking after evening meals, which were the most carbohydrate-heavy and were followed by the most sedentary time. So the American Diabetes Association for all adults suggested for all adults with diabetes to get at least 150 minutes per week of moderate intensity aerobic physical activity and spread the activity over at least 3 days of the week with no more than 2 consecutive days without exercise. But this is a great tool, and nobody's ever said this before. But when this study actually took place, they had people that waited too long after their evening meal to manage their blood glucose, and it had a big difference that people with diabetes reached peak levels in 72 or 74 minutes after a meal, and it would have been much less if they'd gone for a walk right after dinner. So the high blood glucose levels that people with diabetes have after meals are more important than the fasting levels for many people. The activity helps the most when A1C results are on the low side, less than 7.3%. Most mealtime glucose contributes about 70% of the A1C. However, when the A1C results are high, greater than 10.2%, it contributes 70% of the A1C value. So even if your A1C level is quite high, it makes sense to bring it down to normal. And remember this, immediately after a meal, especially the evening meal, walk 10 to 30 minutes. And the evening meal, because that's when most people have their most carbohydrates. If a lot of people have their most carbohydrates at lunchtime when they're retired, then that's the time to have the most. But when you can take your blood glucose level down by 12%, then that's huge. Physical activity, we expect over the long term to bring your blood level down to as much as 20% without taking medications. But if you have diabetes, and it's possible that you don't notice any sign or symptoms of the disease, that's why, like hypertension, they call it the silent killer. You do have some signs, as they may have been. You may become thirstier than normal or unusually tired. Those kind of diseases with symptoms can cause a lot of harm to your body if they go untreated. The one thing that we have that we treat you with is medications, and we need to know how those medications work. And you know that you have a blood glucose meter that measures your blood glucose level as many as 3 or 4 times a day, some people 5 times a day, and you have to take it. When you check your blood glucose levels once a day or several times a day, your levels are a good indicator of how well your diabetes medications are working. So when you start on a diabetes treatment plan, the team will tell you what your personal goal is and what numbers you should see on your glucometer. So everyone's different, but the average blood glucose level for an adult before a meal is usually between 70 and 130, and less than 180 1 or 2 hours after a meal. So if your tests are consistently falling in these range, it's likely you're safe to stay on your medication the way it's working. Now we have that A1C test that we were talking about. And that's keeping track of your blood glucose levels with daily testing is a good way to limit and be in part. But you take this test as often as your doctor wants you to, and may ask you to go for an A1C blood test, which is something that gives your brain 90 days to remember this, and the idea of what your average glucose blood levels are over the previous 3 months. So as with regular glucose monitoring, your own personal goal may be different. The average A1C goal for an adult is 7%. So if your doctor changes your treatment, you may be asked to go for more A1C treatment, more A1C testing. Now, why is this important? It's important because when you're taking a blood glucose reading with your meter and you see it's high and you're due to go into the doctor, then you change your 3 or 4 days before you go in, you change your eating habits. And you take your blood glucose meter reading and you take it into your doctor the day you're in for your appointment, and it looks okay. You can't do that with an A1C blood test. There are 2 times a year, if you have type 2 diabetes, that you don't take insulin and your regular blood glucose testing falls within normal range. If up to 4 times a year, you'll have an A1C test if you take insulin or your blood glucose levels are not controlled, and 3 or 4 times a year if you have type 1 diabetes, which is the kind that you inherit, and you're on insulin for the rest of your life. So although monitoring your blood glucose is a great way to tell if you are behaving yourself, the A1C is how you determine whether or not you've been doing that the whole time. This A1C test is for diabetes management. For the higher your A1C level, the more glucose control that you lack. So when the A1C test comes in, if a blood test measures the amount of sugar bound to hemoglobin, which is the red blood cells that carry oxygen, and doesn't show sudden or recent changes in blood sugar, your doctor will look at those results as more of an average when it comes to assessing how well your diabetes treatment plan is working. The reason you need an A1C test is they will judge your blood glucose levels by the A1C, and also determine whether or not your medication is working or not. And if it doesn't show some results, they will change your medication. The danger of just looking at your blood glucose meter is that you don't know exactly when you started behaving yourself. So if you know you're going into the doctor and the blood glucose levels are within range, they're not going to change your medication. If they're higher and your A1C comes back higher than 7, they know that you haven't been behaving yourself, and they'll put you on more medication. And you may need to be on more medication. We have people that are on 5 or 6 different kinds of medications to control their diabetes. And that's unusual, but it's not unusual to be on 3. So your doctor will be able to tell you when you need an A1C test. You don't have to have a fasting blood glucose level to do this. You can go in at any time. And we, at one time, were having some over-the-counter A1C ones that came out that weren't reliable. They may be in the process of doing those again. But nevertheless, if your A1C level is above 7, that means your medication isn't working and you need to go in and see your internal medicine doctor or your primary care physician to get that adjusted, because a long-term continuation of high blood sugar is going to eventually cause you cardiac death as the end result if it's very severe. And again, you can't tell if it's very severe or not because you're not doing you don't get the symptoms such as blindness over a period of time, all kinds of neuropathies. I'm not a diabetic, but I have neuropathy from my back injuries in my hands so bad that I have to wear some copper gloves to even be able to pick up a pen or pencil at night. I write my checks for the pharmacy in the morning because I can hold a pencil well. In the matter of the evening, it's a little bit more difficult. So those are things that we learn to work with and learn to be part of our actual daily living. And then we do things like go on vacation and we don't take care of ourselves. And if you forget your medication, we talk about this a lot in the summertime because people seem to be traveling more. Today, I don't think, when I got off the airplane yesterday, I thought we were going to an assisted living place. There was so many people that were older than I was, and wheelchairs and those kind of things, and those kind of people are traveling today also, and you don't take care of yourself the way you should. We want to remind you that you're the most important thing to us as your community pharmacy, and we want to make sure that we provide you those guidelines to work within those guidelines to make sure that we take care of you. A lot of people now are starting to get symptoms of the cold and the flu, and people are wondering, how do I know I have the cold or if I actually have the flu? And we really had a series of people the last 2 weeks that thought they had the flu. The difference in this congestion type thing that you get that's a strain of a cold virus, and there's over 70% of those viruses that we don't know what they are. They just attack us. And normally those cause you to be symptomatic, meaning you have possibly a sore throat, runny nose, eyes watering, but you don't necessarily have the fever and the achy joints and pains and things that you have with the flu. When you get those, it's pretty accurate on you having the flu. Now, just because you got the flu now and you hadn't had the shot yet doesn't mean you can't get the flu again. As I've said, there's many viruses that take place both in the flu and with colds. So the chances are if you get the flu shot, that same kind of flu will not repeat itself. We need to remind you that vaccines aren't 100% effective no matter what you get. The Zostavax shot is about 60% effective, as much as 80% effective. The flu shot, again, about 60 to 80%. And if you've already been exposed, it's not going to work. It takes about 2 weeks for these things to take effect. The pneumonia shot, the same way. So just because you get an immunization doesn't mean that you're clear and you're not going to get the disease, but it substantially limits the severity of the disease and the length of the disease state. So if you haven't been immunized, make sure that you get immunized. And if you're taking maintenance medications, make sure that you go through all your medications and know what you're supposed to be taking and not. If not, we put this invitation out before. Please come see us. Bring all your medications, including over-the-counter medications. We'll go through them all with you. If you're not supposed to be taking them, we'll question you, wonder what you're taking them for, and then we'll tell you to discontinue them. If you have duplicates, which is medication, and I used to go to people's homes and I'd look in their medicine cabinet and I'd see the shelves full of medication. Some of it was expired, and some of it they were still taking. I'd see duplications on medication, and I would tell them I was looking in their medicine cabinet. I just didn't go in the bathroom and look in their medicine cabinet. But those are things that you all need to, and if you don't want to come in and do that at no charge, at least make some sensible approach to go into that medicine cabinet yourself and look at those drugs that you have in there. Look at the expiration dates. If they're not any good, get rid of them. We all say, well, we have a few antibiotics left. A few antibiotics can make you sicker than not having any, because it builds you up potentially to think that your body's in control and your immunization and your buildup is enough, your immunizing factor, that you don't need to worry about getting the disease. And then you only take 2 days worth, and it's like pushing you off a cliff. Your resistance goes down to nothing, and then you become more susceptible than ever. So never have any antibiotic left. If you're taking an antibiotic for an orthotic that you replaced, you had a new knee replacement, or you had back surgery and they put some new parts in, don't hesitate if the dentist wants you to take the antibiotic, as we've talked about a couple of weeks ago. That theory is going away somewhat because the risk has been reduced considerably, but you also need to be careful if your dentist is worried about his liability or her liability. If they want you to take a prophylactic antibiotic, I would suggest you do as they suggest to you. It just lowers your risk, and at this point in our lives, with medicine changing considerably, and we don't know how much it's going to continue to change, it may be that we go to a robot. I can't tell you, Paul, how many people that I talked to in New Orleans that were pharmacists, that their wife or themselves had surgery done by a robot.
Really?
And it's becoming
becoming the new thing.
The new thing.
Yeah,
I don't know what that's going to do with the surgery field. People go into medication the same way with pharmacies.
Now, do you know if somebody is actually operating the robot, or if it's a program that's programmed in that the robot just follows?
I think it's probably a program but I don't know. I mean, I've just heard it recently a lot, and there's been some complications with a couple of these that were board members of mine. But I guess that's I don't feel qualified to really talk about it. I just know that it is happening, and it's the same thing with pharmacy. People have dispensing machines today that replace pharmacies. We're in long-term care facilities and in acute care facilities where the pharmacy may fill the machines, but as far as actually dispensing them, that may or may not be happening. So we're seeing healthcare being affected the same way we are seeing other forms of skilled workers and professional workers being eliminated from the scene. So as we see that continue to happen, and then when we want to go see a physician, whether or not there's a physician available to see us becomes pretty discretionary, because in a lot of areas, including rural areas like this, we may not have that choice. I know we do now. but it's diminished considerably to what we had 5 or 10 years ago. We had every kind of specialist there was to have, except for open heart surgery and those kind of things. And now that's changing rapidly with contract physicians and robotics, and all we really care about, I guess, is whether or not we survive or not. And it becomes more a responsibility of us as a patient than it does of the healthcare practitioner, because they are treating everybody in non-specific, and very few people going into private practice for themselves because the risk and the liability is so much greater, and nobody wants to take that chance. So there's always a chance that that will decrease instead of increase as we all struggle in healthcare to be more valuable to our peers that are out there and the rest of our community that really needs some support. So in New Orleans, I saw still results of Hurricane Katrina years ago, and now we have more and more of those places that we're asked to, as we were during the Valley Fire and other fires, to go in and help out as pharmacists and as healthcare practitioners go to other parts of the country as well as our own parts of the country in order to provide needed help. So I want to remind everybody that the flu vaccine is really imminent for you to get it as soon as you can. Remember that you can call us at any time or come in at any time, fill out a short piece of paperwork, and we will immunize you. If you're over 60 and you haven't got the pneumonia shot yet, if you've got one and not the other, come on in and we will immunize you. Remember that as the weather is changing, we are your pharmacy that delivers. We'll be delivering the same areas that we have in the past with Kelseyville, the Buckingham, the Rivieras, and Lakeport and East Lucerne, Upper Lake, that whole area, and Lakeport especially, because that's where we're located. If you need to have your business wants us to come in and immunize you for flu shots, call us at the pharmacy and let us know. We'll set up the necessary paperwork and come in and give your staff the flu shots. I'd like to remind you we're North Lake Medical Pharmacies with 2 locations for you. The 5136 Hill Road East across from Sutter Lakeside Hospital. Call us there at 263-6192. Or outside the Bruno Shop Smart at 347 Lakeport Boulevard. Give us a call there at 263-1328. Thank you, Paul.
Thanks, Bill. We'll see everybody back here again next Wednesday at 10 a.m. here on AM 1270 and 96.5 FM KXDX Lakeport.